Thank you, Chairman. It is my great honor to be here, and I greatly appreciate ESMO faculty member good opportunity to make a presentation. Today, I would like to talk about where are we with checkpoint inhibitor in gastric cancer. This is my disclosure. This slide shows a molecular subtype of gastric cancer in both TCGA and ACRG classification. TCGA, as you know, USA divided 4 subgroup gastric cancer type groups, and EB virus and PD-L1, PD-L2 overexpression, immunocell signaling, and ARID1A1 mutation and hypermutation in MSI high is a good candidate for PD-1 or PD-L1 antibody treatment. Also, Asian classification, ACRG, EB virus infection or enrichment of EB virus tumor, hypermutation or ARID1A1 in MSI high type is also the good candidate for PD-1 or PD-L1 antibody treatment. This slide shows the escape from immunosurveillance. Look at the suppression of T-cell activation by PD-1, PD-L1, or PD-L2 interaction is an attack against tumor cells off and leads to escape from immunosurveillance. However, anti-PD-1 therapy leads to deactivation of T-cell by suppression of PD-1, PD-L1, or PD-L2 interaction and attack against tumor cells and lead to killing of tumor cells by deactivation of T-cells. This is a cancer of immunity suppression by anti-PD-1 therapy mechanism. This slide shows us very busy, I'm sorry, so many clinical trials using molecular targeting agents, including PD-L1 antibody for metastatic gastric cancer, were conducted so far all over the world. First-line treatment and second-line or second-line or third-line later treatment, many biologic agents were conducted. However, disappearance trials all negative in terms of overall survival. And red color highlight is a positive overall survival. Just only trastuzumab was first line, ramucirumab was second line, apatinib was third line in China only, and ramucirumab was third line, just only 4 agents. And black highlight trials is now ongoing trials. And this slide shows the treatment pathways that are currently under evaluation for gastric cancer. Look at this slide. In terms of HER2 therapy, is a trastuzumab only the active for gastric cancer compared to T-DM1 rapatinib pertuzumab positive active for breast cancer. Regarding angiogenic agents, ramucirumab alone or apatinib is the only active agent for gastric cancer compared to bevacizumab pluvicto is a regorafenib or active in colorectal cancer. EGFR status 3 is all trials are negative, and FGFR MET is a targeting agent is a very questionable. Now we have very active agent, immune checkpoint inhibitor, including nivolumab. This slide shows a meta-analysis to indirectly compare the efficacy profile overall response or PFS between anti-PD-1 antibody and anti-PD-L1 antibody monotherapy. You can see here, in terms of overall response or PFS, PD-1 antibody treatment is a better rather than PD-L1 antibody in terms of response on PFS across tumor types. Very consistency data. Also, gastric cancer, GE junction cancer is also similar. PD-1 antibody monotherapy is more active for PD-1 antibody monotherapy. As you know very well, Attraction 02 trials already reported by Lancet. Overall response rate, nivolumab arm is 11.2%. Progression survival is significantly better in nivolumab than best supportive care in hazard ratio with 0.60. Also, overall survival shows a clear benefit compared to best supportive care with hazard ratio of 0.63. And then this data is in Japan is nivolumab for third line or later gastric cancer treatment was approved last September 22nd. And I'm sorry, last year, September 22nd. Also, Keynote 059 trials shows a clear benefit over response over PFS and OS of PD-1 antibody pembrolizumab. But just this trial is a phase 2 trial, large phase 2 trial. Response rate is very similar to nivolumab, 12% in all patients. PD-1 positive is at 16%, and PD-1 negative is at 6%. PFS and OS is a little bit better in PD-1 positive gastric cancer rather than PD-1 negative gastric cancer. And then FDA approved pembrolizumab for third line or later gastric cancer. But the gastric cancer having PD-1 positive, only PD-1 positive. Nivolumab all-comer approved in Japan. Pembrolizumab approved in US in PD-1 positive only gastric cancer. Both is a third line or later line. Which is better, nivolumab and pembrolizumab? This slide shows Attraction 02 and Keynote 059 trials, the data. Efficacy data is pretty similar between two agents. Overall response, median overall survival, 12 months overall survival rate is quite similar between two agents. In terms of efficacy, these agents is identical. Okay, clinical question, which is better in earlier or later line in case of using anti-PD, PD-L1 antibody for GEJ junction cancer? This is my answer. Probably earlier line is better in terms of efficacy over response or over survival. I would like to explain this answer. From standing point of clinical view, I would like to explain non-small cell lung cancer data. We should learn more and more non-small lung cancer story in terms of PD-1, PD-L1 antibody. You can see here, Keynote 001 shows a treatment-naive patient overall survival median is more than 20 months. However, previous treated patient median overall survival is just 10 months, 2 times better in treatment-naive patient in non-small lung cancer, PD-1 pembrolizumab monotherapy treatment. And also, overall response is 58% of previous treatment-naive population as shown, and on the other hand, 38% of response are shown in previously treated patient. Also, Keynote-024 study design, as shown in this slide, overall survival, clearly showing the benefit of overall survival. Pembrolizumab monotherapy is a TPS 50% or higher PD-1 positive patient. Median overall survival is more than 30 months. So good data, very similar to Keynote-001 treatment-naive patient. I move on to gastric cancer. You can see here, Attraction 02 and Keynote 59 Cohort 1 is a quite similar result was observed in terms of efficacy, response, median OS, and so on. You can see here, left side column, Keynote 59 Cohort 3 is a monotherapy of pembrolizumab, PD-L1 positive gastric cancer. Overall response rate is 2 times better, and median overall survival is 4 times better, quite better in monotherapy in first-line treatment for PD-1 antibody monotherapy. You can see here waterfall plots. See, 77% of patients experienced the reduction in target lesion size in cohort 3 first-line treatment. On the other hand, 42 or 37% experienced the reduction in target lesion size in later line monotherapy treatment. I move to preclinical basic aspect. Phylogenetic tree analysis was shown, clonal and subclonal neoantigen. Primary tumor consists of different subclones with shared and private somatic alterations. Alterations shared by all tumor cells occur early in tumor genesis, represented by the blue trunk of the phylogenetic tree. Alterations shared by tumor cells present in some regions of the tumor, but not all, B and C, occur later in tumor genesis, represented by the yellow branches of the tree. And private alterations, D, E, F, present in only one region of the tumor, also occur later in tumor genesis, represented by the red branches of the tree. Heterogeneous tumors are composed of multiple subclones and under selection pressures, such as chemotherapy or cytotoxic agents. Subclones with either intrinsic or acquired resistance can be selected for, allowing these subclones to dominate a tumor mass and potentially drive disease progression. This slide shows that clonal neoantigens elicit the T-cell immunoreactivity and sensitivity to immune checkpoint blockade. You can see here a relationship between clonal neoantigen burden and overall survival in primary lung adenocarcinoma was observed. Sensitivity to PD-1 blockade in patients with advanced non-small cell lung cancer was enhanced in tumor enriched for clonal neoantigens. T cells recognize clonal neoantigen were detectable in patients with durable clinical benefit. Durable clinical benefit is the green side, and left side is no durable benefit in the cytotoxic chemotherapy induced subclonal neoantigens, contributing to an increased mutational load were enriched in certain poor responders. This means that after chemotherapy, PD-1 or PD-1 antibody therapy is not so ideal, I think. Next clinical question is what is a biomarker of anti-PD-1, PD-L1 therapy in GEJ injection cancer? Several biomarker candidates exist. First is a PD-L1 expression, maybe, but has not been established robustly. Also, TMB, probably yes, but few data in gastric cancer. However, MSI high, without doubt, definite biomarker, I think. Previous, Dr. Shitara presented Keynote 061 trials overall survival, CPS 1% data are shown in this slide. Very expressive close trial design. Kaplan-Meier is closed. I do remember close Kaplan-Meier curve is, I do remember IPASS trial for non-small cell lung cancer adenocarcinoma. This was a progression survival, Gefitinib versus carboplatin paclitaxel cytotoxic agent treatment. You can see here, firstly, good cytotoxic agent treatment, but later as a bad worse. Very, very similar to Keynote 061 trials. IPASS trials, progression survival is a first point is a worse in Gefitinib. However, later period is a better compared to cytotoxic agent. What means? It is selected patient and divided two groups. You know, EGFR mutated type non-small cell lung cancer is a strong biomarker in non-small cell lung adenocarcinoma. Post-hoc analysis shows a clear benefit of EGFR mutated Gefitinib treated compared to carboplatin paclitaxel doublet chemotherapy. Also, Keynote 06 trial is a better later development data means biomarker exists, I think. One candidate is a CPS 10%, is a number of patients, 108 patients. Out of ITT population of 18%, out of CPS 1% or higher population, this CPS 10% patient population number is at 27%. Also, MSI high is out of ITT population, just only 4.6% exist. And however, CPS positive and MSI high is highly overlapping, and around 20% of patients is having the better efficacy shown using PD-1 antibody. On the other hand, Attraction 02 development trials, biomarker studies failed. PD-1 negative or positive is regardless of PD-1 positivity, survival benefit of nivolumab was shown. However, these trials examined only 40% of patients biomarker study. Also, we have to learn non-small cell lung cancer in terms of tumor mutation burden. You know, Checkmate 227 trials recently published by New England Journal of Medicine, high tumor mutation burden is clearly showing the better ipilimumab plus nivolumab survival benefit compared to chemotherapy as control. On the other hand, low tumor mutation burden is a contrast data. Chemotherapy is better. In gastric cancer, MSI high type gastric cancer is using cytotoxic agent chemotherapy is worse compared to non-MSI high population. On the other hand, TMB, tumor mutation burden high population is very effective to immunotherapy compared to low TMB population. This ASCO meeting, TMB for GEJ cancer study was reported. Left side column, Scrum Japan in Japan, OCP panel, 143 gene platform, and examined, and concordance are checked between OCP panel and whole exon sequencing. Very similar concordance were strongly shown. However, of course, panel is very possible instead of whole exon sequence, but optimal cutoff is not established. Right-hand side, you can see here, MSK impact. More than 400 gene platform are shown over survival. This is the CTLA4 antibody and PD-1 or PD-L1 antibody as a clinical trial cases are examined. 7.3 mutation per megabase or higher, high tumor mutation burden is a quite better rather than low tumor mutation burden in terms of overall survival.
Yeah, exactly.
Are there any substantial rationales regarding IO combo therapy? Of course, answer is a many candidate, cytotoxic agent, IO molecular targeting agents, or IO radiotherapy exist. Regarding combined with chemotherapy, is it good or evil? Of course, chemotherapy has complex and pleiotropic effects on anti-tumor immune responses. Cytotoxic agent chemotherapy leads to promotion of anti-tumor immune response. On the other hand, in terms of some factors and some situations, cytotoxic agents chemotherapy leads to impairment of anti-tumor immune response. Anti-PD-1 antibody enhances the positive immune effects of chemotherapy and reduces negative immune effects of chemotherapy. This also the cytotoxic agent enhances immunological reduction around tumor and tumor microenvironment. Several anti-cytotoxic agents revealed to abrogates MDSC T-leg activity and enhances cross-priming, promoting anti-tumor CD4 T-cell phenotype, promoting cell recognition and lysis, and augments of dendritic activation. And the effect of chemotherapy and radiotherapy on the tumor microenvironment are shown in this slide. Of course, I'm sorry, and I do not have any time, and I'll skip this slide shown. And then, combined with chemotherapy plus PD-1 antibodies, the good data are shown, attraction 0.4. Response rate is around 70%. Also, pembrolizumab, same result as shown, 68% combined chemotherapy as a first line, but a little bit disappointment, median overall survivors, just 13 and 8 months. IO, Checkmate 032 is promising also. Nivo 1 plus EP3 is a response rate 24%, a little bit better. Nivo monotherapy or Nivo 3 or EP1 therapy. Response were observed regardless of PD-1 positivity. Now, ongoing, first-line combination trials ongoing. Keynote 062 using pembrolizumab, Checkmate 649 using nivolumab, and attraction 04 also using nivolumab. And anti-angiogenic agents, for example, LAM plus pembrolo, as rationale exists is a definite style, and very good data. And also, LAM plus durvalumab is also second line or later line. Response rate 50% is a good data as shown. In Japan, nivolumab plus ramucirumab as a IIT P2 trial is a very good data as shown in this ASCO meeting. 24% of response rate, and disease control rate is 62%. Also, paclitaxel plus LAM plus nivo as IIT P2 trial is now ongoing in Japan, and already enrollment just finished. Also, anti-HER2 therapy for breast cancer, gastric cancer, pluripotent trastuzumab. breast cancer, pembro plus trastuzumab is good data as shown, keynote 014 trial.
I'm afraid we have
Sorry. And the last 1 or 2 minutes. And the pembrolizumab plus margetuximab treatment is pre-treated trastuzumab. It's very good data. Response rate 29% is very good data. Other combined therapy are shown in this slide. IO radiotherapy is also very promising. Abscopal effect, radiation upregulates PD-L1, durvalumab, and Pacific trials are maintenance after radiotherapy is very good data. Nivolumab plus radiation and head and neck cancer is a little bit better, but not significant. Okay, last slide show OS data from global trials against G-junction tumor. And I'm very expecting, in summary, anti-PD-1 antibody monotherapy, pembrolizumab, and both active and having similar efficacy in late-line gastric cancer, but the efficacy is limited. Anti-PD-1 antibody combined with other agent is very, very promising, or earlier line therapy is also expected. The role of PD-L1 expression and the relationship between PD-L1 expression and efficacy are needed to be further investigated in G-junction cancer. Many clinical trials in any line or any combination are now ongoing. These results will be confirmed as a definite therapy for G-junction cancer. Thank you for your kind attention.